Welcome to everyone. Pleasure to be here tonight. We're going to start our symposium, Bruton Tyrosine Kinase Inhibitors, Updates and Advancement in the Treatment and Management of CLL, SLL. I'm Javier Pinilla. I'm a senior member and director of immunotherapy and head of the lymphoma section at the H. Lee Moffitt Cancer Center in Tampa, Florida. And I have the pleasure to introduce also my co-host, and really, here we are, okay. Dr. Farouk Hawan, professor of internal medicine and director of the lymphoid malignancies program at the Harold Simmons Comprehensive Cancer Center in the UT Southwestern in Dallas, Texas. And I guess someone had to really pass the slides. Here's the faculty disclosures, as always in these types of presentations. Let's see now if this is working. Thank you very much. You can review this information. And again, okay. I have to read this. This program is provided by HMP Education, an HMP global company, and is supported by an independent educational grant from Beijing, USA, and Pharmacyclists LLC, an AbbVie company, and Janssen Biotech, administered by Janssen Scientific Affairs. Let's see. Well, this is the learning objectives. I'm not going to go in detail. You can really go through. We're going to really evaluate safety, efficacy of these new emerging target therapies. And we're going to really discuss real-world data also of these BTKs alone and in combination. We will really discuss appropriate management of the plans utilizing all these drugs in the relapsed refractory as well in the front line, and other things that you can really hear. Well, and now I'm going to really introduce, and again, I already introduced Dr. Awan, who's going to really start the presentation of his part. Thank you.
Thanks, Javier, and thank you all for coming. I see some people that were there yesterday. I had a similar session, so I am afraid I can't use the same jokes now, so that's going to be a problem. So I'll come up with some new stuff, hopefully. I was thinking about it, but I'm happy to be here, and hopefully we can all go over some of the recent advances in CLL. I said this before, I say this every time I'm at these meetings. I love an interactive session online or in person. If you have questions at any point during the presentation, feel free to interrupt. It's so much easier and to answer it at the spot. And it's also, we can go back and forth with the slides and show you the right context and the data. And I'm sure Javier would be happy to participate in that too. So it gets us more engaged, gets us more involved, and it's more fun for everyone. So by all means, please feel free to interrupt. The other thing I wanted to say before I start is that these are excellent times for CLL. I mean, we were just arguing about rates of AFib and MRD business and 5-year progression-free survivals. And I look back at this situation 10 years ago, and we had nothing. And so I think it's great options, great opportunities for our patients. We've come a long, long way, and we're doing a really good job for our patients now that we are able to argue about these nuances in the management of patients with CLL. So I think we're all blessed to be in a setting and practicing in a setting where we can really improve the lives of our patients for a very long period of time. And we can argue and fight about one drug versus the other all day long. But at the end of the day, I think it's all in the best interest of the patients that we are able to fight about these nitty-gritties. So with that, we'll start with BTK inhibitors. Obviously, the first ones were the Brutonib and then acalabrutinib and so on. So we've come a long way from the first approval to now, so I'll go through the journey very quickly. You've seen this 100 times, and I've said this before. This is the most cited abstract ever, probably, because it's on every single CLL presentation, because we've been using it since 2018 when it showed up on an abstract that then we took a PDF of that and then it's copy-pasted. It's never been published. There is no kinome profile that's ever published like this. Every drug has its own kinome profile with different figures, but this is what it is. But basically it tells you the sizes of the dots. If it's limited red dots or clustered in one area, that means it's more specific. If it's all over, it's a little more non-specific and hits a lot of targets. Bottom line here is that all of these drugs are very, very effective in targeting the BTK. Both ibrutinib, acalabrutinib, and zanubrutinib, all three of them are very effective drug. Really, the problem is in how it's targeting other kinases, and that's how the toxicities are manifested. So that's really the argument. And then if you have a very specific drug, sometimes you will have a lower toxicity if that target is not causing the issue. Obviously, for example, if you have a lot of EGFR targeting, you might end up with a lot of rashes and so on. So there also has been some evidence that off-target effects can actually be beneficial. So for example, ITK targeting can result in T-cell modulation, which helps sustain some of these responses in long-term disease control states in ibrutinib, for example, and that's kind of what's reflected in this. Bottom line is we can learn a lot from these kinome profiling for these drugs, but it's not just about specificity. They say ITK modulates TCR. Does this apply to all BTKs? That was the question that just came up. So it modulates Th2 to Th1 differentiation, so it changes the immune subtype, not necessarily through the TCR, but through ITK targeting on T cells. This does not apply to all BTK inhibitors, because if you look at the IC50s here, which is basically, is it physiologically achievable? So at physiologically achievable IC50s, acalabrutinib should not hit ITK, and ibrutinib and zanubrutinib might hit ITK. Ibrutinib definitely hits ITK. So 10 nanomolar or 4.9 nanomolars is a achievable concentration where ibrutinib achieves it in the serum, and that's why it can hit ITK and modulate it. Whereas more than 1,000 nanomolars, it's a pretty high concentration that is not physiologically achievable by just twice-a-day oral dosing for acalabrutinib, for example. So this is great. This is exactly what we wanted. So I just answered a question which came up about the T-cell signaling. So anyway, so the point of this slide was that specificity is important, but sometimes non-specific effects can cause toxicity, but can also improve efficacy. All right, so you've seen this before. You're all familiar with this data. Chemotherapy has no role in CLL. This has clearly been shown in the Alliance study in older patients and also in the ECOG study in younger patients versus FCR and BR. And that's basically what this data shows. Combining it with rituximab doesn't matter with BTK inhibitors. There's also updated versions of these slides that the argument was that if CR is useful in patients who are IGHV mutated, that if you are IGHV mutated and if you get FCR for 6 cycles, and if you end up with MRD negativity, which is at least less than 10 to the minus 4, then, because that was the assay that we were using back then, and if you don't relapse by the year 7, then those patients may not relapse. That's a very small subset of patients, and those are the patients who would be expected to do well anyway. So FCR was working very nicely for patients who didn't need it. That's the joke. But anyway, but the argument was that some of those patients can potentially be functionally cured and may never have to deal with this disease again. And that's not a bad argument. That's a pretty relevant argument. And that's why we've been stuck with FCR. But having said that, ibrutinib rituximab with the mutated cohort showed that there is improvement in outcomes with that categorically. So that was the last argument. Having said that, people still argue that, hey, but that's continuous therapy and you might have continuous side effects. The problem is if you get MDS from FCR, you can't really do much about it, and that's a pretty bad outcome, and that's 9 to 10% of patients. So we want to avoid side effects, and hopefully with some of these newer agents, we will not use any more chemotherapy and avoid all the side effects of chemotherapy. This is a problem, and I'll just highlight the main issues. We've all been hearing about these issues all day: atrial fibrillation, bleeding issues, cardiovascular toxicity. Those are the main ones, and this is more pronounced in the elderly. This is just, again, one example. There are multiple such examples. The UK FLAIR study. Basically, anytime you use ibrutinib in patients above 70, you have a higher probability of getting cardiovascular issues. Obviously, those patients have underlying cardiac disease, and they can get more issues more frequently. but the rate of sudden cardiac deaths is also fairly high in patients above 70 as compared to the younger patient population. Elevate-TN was one of the first ones with acalabrutinib that compared it in the frontline setting. Very interesting, important study in the sense that it compared acala to chlorambucil obinutuzumab. Not that exciting, but what was exciting was that it had the obinutuzumab plus acalabrutinib arm, and prior to that, we felt that CD20 antibodies don't really add to the efficacy of acala or BTK inhibitors, as had been shown on the Alliance study that I just showed you. Ibrutinib doesn't add to it, but in this particular trial, there was an improvement in outcome with acalabrutinib with obinutuzumab. The study was not designed to look at that, but still, it's a 12% difference in progression-free survival at 5 years. That's pretty provocative, and at what point does that translate into meaningful clinical outcomes? The other problem is that this also happened kind of sort of around the COVID era, where CD20 antibodies were causing a lot of issues. Patients were getting more immunocompromised, and COVID outcomes were pretty dismal. Now, fortunately, we're back to the pre-COVID era, and COVID is here to stay. We can treat it very effectively. Vaccines still don't work for our patients with or without CD20 antibody. It's going to be worse with a CD20 antibody. But regardless, we can do a pretty good job with COVID now. So I think for a lot of patients, this extra 2, 3, 4 years of disease control and with a single pill twice a day with 6 months of IV therapy, I think this is a pretty nice deal for a lot of patients. Obviously, there would be a debate and discussion with the patient, but I don't think it's an unreasonable option to at least offer or discuss with the patient. May not be that effective in patients with 17p deleted disease or TP53 mutated disease. Again, we keep on talking about the adverse events of special interest. Those are the bleeding issues, the AFib issues, the cardiovascular issues, and then infections and cytopenias. Those are the main ones. Acalabrutinib seemed to be fairly well tolerated, still had the same class effect. In my mind, these are class effects. Again, we can argue about which one is worse and which one is better, but I feel that AFib, bleeding, hypertension are class effects, and then there are some that are higher in one versus the other, but essentially all BTK inhibitors, at least the first generation ones, all 3 of them have similar side effects that we have seen so far, with minor differences in between them. Another important entry in the CLL space is another BTK inhibitor, irreversible covalent BTK inhibitor, zanubrutinib. Very promising early data, shows very promising outcomes as compared to chemotherapy. Another nail in the chemo coffin. Basically, no reason to use any chemotherapy, including BR or FCR. Some people argue, no, I have a patient in the hospital and I want them to get immediate disease control. The response duration or time to response with zanubrutinib, acalabrutinib, even ibrutinib is less than 2 months. I mean, you will get a response pretty quickly if in the nodal burden. And yes, you will have leukocytosis, but you don't need chemotherapy for that, and most leukocytosis can be easily managed. Occasionally, you can get away with Rituxan or obinutuzumab. If you want to get the white count down rapidly, you just have to be careful with tumor lysis, but you don't have to use chemotherapy. I cannot imagine a situation where I'm absolutely compelled to use chemotherapy. Maybe in a very unique situation, I might have used chemotherapy, but that is definitely not the first, second, third, or 10th thing that's on my mind. Even in a bad situation, I shy away from chemotherapy. Again, we want to compare the cardiovascular issue, the hypertension, for all of these drugs, and it seems that the bleeding issues, the cardiovascular issues appear to be better with zanubrutinib as compared to all the other BTK inhibitors, but it still has the same similar class effects. It does have bleeding issues, cytopenia issues, and then the cardiac issues are not as bad, but we will get into more detail in a little bit. So this is what I've already talked about. You have to think about bleeding issues, think ahead. For minor procedures, hold the ibrutinib for 3 days. For major procedures, 7 days. If you have a bleeder, patient who's bleeding after an accident, you can always transfuse platelets because that's really the treatment in an acute situation. So just be careful. And I think this is also important for non-hematologic oncology specialties, just like if they go to a surgery, they ask you about Lovenox, they ask you about heparin, they ask you about aspirin, and they stop it 7 days before. Just do the same for our drugs. But the problem is the attitude that most, even my residents and non-heme fellows is, oh, this is a Brutonib, this is an oncology problem, call the oncologist. No, it's not an oncology problem, it's everybody's problem. Just like your aspirin is my problem too because it's my patient. The problem is it's not rocket science to stop an ibrutinib, which can potentially result in bleeding. So, they don't pay attention to this. We're all smart people, but historically we've deferred this management to oncology. Oh, it's the chemotherapy. Deal with it. So I've been trying to overcome that, at least with our discussions. Same thing we've discussed about atrial fibrillation. Rate control seems to be the better approach. Rhythm control doesn't seem to be as effective. Again, this is a discussion with the cardiologist. So beta blockers is the standard first line. Other agents can have interactions with the BTK inhibitors, so you have to be careful with that. It's not an absolute contraindication to discontinue BTK inhibitors. Hypertension is the same way. You just have to be aggressive, stay on track, and in refractory cases, you can also consider dose reduction. So now we have the non-covalent or reversible BTK inhibitors, which are also binding at a different site and may be active, and they are active in patients who have had prior BTK inhibitors. The first one was nemtabrutinib and then pirtobrutinib. We won't go into nemtabrutinib. We will have an update later on this week at EHA. But pirtobrutinib is shown very preliminary, really important activity in patients who have failed both BTK inhibitor and also BCL2 inhibitors. So it's very promising. We're looking forward to more data and see how this evolves. We're looking at 19 months disease control rates early on with patients who failed both BCL2 and BTK inhibitors. So very provocative and very promising, but still very, very early. We need longer follow-up. We also know that the mutation profiling can be different with pirtobrutinib, so it should not, absolutely not, be used at this point before acalabrutinib or zanubrutinib or ibrutinib. I think that's a categorical statement at this point. We should not encourage the use of pirtobrutinib before the covalent BTK inhibitors. I don't think we have any data to support that approach. We might be actually doing a disservice because right now we know that pirtobrutinib works if ibrutinib, acala, or zanu doesn't work. But we don't know the other way around. And we should not use it unless we know if that is not an issue, because we don't want to lose our really effective first three options. It is well tolerated. We don't see some of the usual issues. We do see some bruising issues. We'll find out what happens with this. We just need longer term follow-up. Like I've shown you, when you look at the clinical trial data, the incidence of all of these side effects are pretty low. But then when you have real world data, it looks much worse because real life problems happen. So at this point, Berto looks really good. We just need longer term follow-up. Very low frequency of all side effects. It's a pretty clean drug so far. Again, very early times, a few hundred patients. We just need longer follow-up. This is kind of the study that I was talking about. The one patient who had recurrence of the bleeding in that 11% group, the yellow one, was the hemophilia patient. In hindsight, that was stupid, but it is what it is. But basically, this study showed that if you have patients who stop ibrutinib because of side effects, you can treat them with acalabrutinib, and most of the side effects don't happen. And same thing, Mazir Shadman presented this, was that if you do the same thing for zanubrutinib, it does the same, and there's an update of this too. And so basically, patients failing ibrutinib or acala for whatever reason, switching to zanu, are able to handle it, and they don't have recurrence of their side effects. But this is the problem. Patients who discontinue frontline ibrutinib for progression, or frontline BTK inhibitor for progression, they have a very dismal outcome, or used to have a very dismal outcome. But if you are stopping ibrutinib, acalabrutinib, or zanubrutinib for reasons other than progression, those patients actually do really well. And a lot of times you can afford to manage those patients with active surveillance until they again get lymphadenopathy or anemia or splenomegaly or whatever, or thrombocytopenia. But because the median time to next treatment is around 2 years or so. So I think this is why it's important to kind of wait if you get somebody off of ibrutinib or acalabrutinib. and zanubrutinib. So there was a question similar to this, is when you take a patient off of BTK inhibitor because after a long time of intake, no cancer cells are detectable, does the immune system recover? So one, there's a good point. So the point here was that can you take somebody off BTK inhibitors and if the immune system recovers? So first thing to understand is CLL is a cancer of the immune system, so your immune system will unfortunately never be normal regardless of time-limited or unlimited therapy because it's an inherent defect in the B cells. So yes, you may have improvement in the B cell system and in the whole humoral immune system, but it never recovers to normal, number one. Number two, we typically don't get into a very deep remission with BTK inhibitors alone. So that never gets to a point where there's no cancer cells detectable. We have had a few patients just on BTK inhibitors who do get into MRD negative disease, but those patients are not that many. So we always are able to find circulating cells on BTK inhibitors, the vast majority of cases. Now with different approaches, you can get into a very deep remission, but does that mean that your immune system will recover after you stop? Maybe after a year or so, but it's never going to be back to normal, unfortunately. All right, so this is kind of what we have talked about. Headaches, caffeine works very nicely. Acalabrutinib is primarily responsible. Lymphocytosis happen nicely in all BTK inhibitors. That's actually a sign that the patient is compliant and taking the pill. And then rashes can happen, secondary primary malignancies. So that's why screening is important. Vaccinations are important. Very quickly, in the last few minutes, we'll talk about BCL2 antagonist. Obviously, the only one we have is venetoclax. Time-limited therapy, 12 months with obinutuzumab. Shows that there is significant improvement versus chlorambucil and obinutuzumab. MRD, the deeper the remission, the longer it lasts. Pretty simple concept, no arguments with that. But remember, what was the 5-year outcome with all comers? 63%. Who are the patients who get into long sustained remission? I don't know. If you tell me who those patients are, I'm happy to use this right off the bat for everyone. Except the point is nobody knows who those patients are. And guess who don't do well with venetoclax and obinutuzumab? It's the one who's TP53 mutated and unmutated, patients who need it the most. So this is why obinutuzumab venetoclax is a perfectly reasonable time-limited option, but you will still have to treat it at some point in the future for the vast majority of patients. And then my argument for and against would be that that's great if you want a time-limited option, but then if your objective is to make the patient live for 15, 20 years, let's say, how many times can you repeat the venetoclax? And maybe you can do it 2 or 3 times and then do BTK inhibitors and then maybe make it to the 15-year mark. I just don't know that. There isn't data for that. Or maybe you can stay on BTK inhibitor. Ibrutinib looks awesome at 7, 8, 9 years out. 70% of the people are still doing well. And then you switch to venetoclax, which we know works. That's another approach because the goal is to get to the end of those non-natural lifespan. Anyway, venetoclax has its issues, but it's a very effective drug. It causes thrombocytopenia, neutropenia, cytopenias essentially. Also, first cycle neutropenia and cytopenias are more problematic, especially when you combine with obinutuzumab, and that's what you have to be careful about. So sometimes there are ways around it. Another important study that was recently published, what antibody you should use, is the CLL-11 study, which answered an important question, that obinutuzumab is the antibody of choice. In my practice, I don't use rituximab in the frontline or relapse setting. I understand some people might argue with this because there's not a lot of data in the relapse setting with venetoclax and obinutuzumab, but I use venetoclax with obinutuzumab almost exclusively unless forced by an insurance company, and that's just been my bias and choice, and it works very nicely. We've tried to move away from rituximab. So bottom line, is there a better option? No, not really. We have to talk to the patient preference, comorbidities, and then come up with a plan that works for them. And this is why we have to talk about the side effects, secondary malignancies, and then lastly, the CLL-13 study, which just came out, which was the whole argument. And now on Monday, we have the IVO versus IO study. But this was an important study which basically showed very durable remission with triple therapy. So think about it. You're throwing all your bullets up front and just hammering it out. But then if you look at the outcomes, the venetoclax obinutuzumab arm is almost as good as the triplet arm. So why are you using up all your bullets up front? Unless you identify that patient who will do really, really well and be in remission 10 years out, it makes sense to use it in that patient. But for all comers, why should I not hold my ammo back And what are my most important ammo? CD20 is not my most important ammo. It is important, but it's not the most important. Most important is BCL2 and BTK. In my opinion, I need to hold one of them in my back pocket for the bad days which are coming ahead for our patients, because this is not curing anyone. Tumor lysis risk, we'll talk more about that. Very effective options, we're spoiled for choices, but I'll let Dr. Piniella talk about more of these. But these are good times for us, and thank you for your attention.
Thank you for this outstanding presentation, Farouk. Thank you so much. You can argue that I'm going to review similar concepts, right? I will argue that we have a very similar thoughts. Farouk and I know each other for many, many years, right? But I think we may have different flavors when we really approach that. And there is no doubt that we are in a fantastic time for CLL patients, right? But also I will say that although we may go into the era of the multiple myeloma like that no one understands much what you to do, I think we need to start to really thinking very well how will individualized therapy in the future to our patients based on multiple factors that obviously Farouk has illustrated very well. Comorbid conditions, because our patients are all really age, as we say, cardiac, but also genetic factors and obviously many, many things that may really produce this problem. So there is no doubt that BTKs has really brought the change of paradigm, the change of paradigm that we have for many years using chemoimmunotherapy, and I fully agree that chemotherapy is gone for our practice, or at least in general, right? Someone, as Paulo Ies said, that in many of the trials, BR is still doing very well in the mutated, but it's kind of a joke. This chemotherapy we don't want, we stay away. But I think, I put this Jin Jan story because I think the dilemma continues, because we used to have the dilemma in the beginning, chemo versus long-term therapy, and then we say, yes, long-term therapy is the best. We already see this beautiful data, this long-term data illustrating how successful is the BTK in the long-term control. Very, very low progression in patients in the lower year, we're going to see them, but obviously toxicity associated with long-term outcomes, more in the first generation, less in the second generation. So how are we going to really introduce this fixed duration, and who are the patients who may qualify? Thinking that many patients, and I'm sure Farouk has in the clinic, say, doctor, I don't want to be in therapy for life, right? Starting from that, and obviously, I'm not going to really discuss about this slide. Obviously, we know that this BTK is essential, but I have to also point it out that it's not only essential for the BCR signaling. There is also BTK involved in many other areas, right, including these integrins, chemokine receptors, and other things that they are very, very important, and the reason why this drug works very well, or at least why BTKs work very well, right? So BTK is involved in many, many areas of signaling, right? So, and again, we can go back about these off-target effects, about the possibility that in certain drugs like ibrutinib may or may not really have a role. I think the ITK story is very interesting, but sometimes never been really put in the work, maybe in the CAR-T because the decreased toxicities. So we saw that, and I think once again, it's being seen the most really used slide to really introduce the new era of BTK inhibitors. And I think I want to point it out something that I think Farouk already said, that there is different really targets, right, for these drugs that you see bigger, lower, intermediate, you name it, right? But there is no doubt that we are really discussing that, as very nicely has described Farouk, we are talking about class effects, right? BTK by definition, and we're really going to continue to say that bleeding, hypertension, cardiovascular effects are there in different degrees, right? We always discussing these tech kinases, this CSK, this mice model that may be really responsible for this higher amount of AFib in ibrutinib, but at the end of the day, you see them with other drugs. So the question is, what is the patient, as Farouk was pointing out, who may or may not? That another important point that, and I learned because my life is kind of a hybrid between myeloid and lymphoid, right? I've been done chronic myeloid leukemia forever, right? And we have the same story. We have the first generation TKI, the second generation, and we start to deal with cardiovascular toxicities with the second and these new drugs, even the ones that we have the Pirto for CML is obviously ponatinib. But we learned that all the trials that were completely, bad in terms that we never really knew about those things to start with. So the patients that they introduce, they are completely random. Obviously, they are older patients, but when you talk to the cardiologist, well, you cannot make much conclusions because those patients, you don't know who is at risk. There has never been defining the eligibility criteria outside these, bad CHF or things like that. So I think it's something that also I always like to really bring because we don't have the data about studying those patients at the beginning because, we have these fantastic drugs and they say, all comers, we love them, right? So obviously, this is the NCCN guidelines, and you have seen that. Obviously, we continue to have our preferred regimen and another really lines of therapy for 17P. The truth is that all these other drugs that we have in the front line, we continue to have experience, as Farouk was mentioned very nicely. We need to really keep seeing then how they're going to develop. We didn't see some of the signals with ibrutinib early on. We see them later on, so we have to be aware. And we have to really also work very well with the cardio-oncology, something that we did in the CML era and we are doing right now in the CLL era with this drug, because I think this also can improve the outcomes of our patients. We need to understand how those patients risk and benefits and how we can introduce these drugs. Obviously, I have to review the same information that Farouk has done, and I need to really discuss again the long-term data. And the long-term data illustrate what he has said. Very, very nice, not reached really PFS after really 8 years of follow-up. And again, no difference. I always really love to really remember the story of the 11Q. We thought the 11Q with the BTK is going to be the best drug for a reason that no one understood, because they were doing even better than the non-11Q. But at the end of the day, we knew that was not really true. Similarly, we're still debating why mutated and mutated is no difference, because theoretically, when you have an unmutated IgHV, you signal through the PCR, and then you may really account for this better control, but it's not. At the end, it's not really a difference when we really see this long-term follow-up. I think what it really fascinates me, and I think you can really see the same thing with ECOG 1912, is the fact that the progression on drugs, that can be tolerated, is very small. The only caveat, obviously, this trial excludes del-17P, although it has some patients with TP53. But you see here only 13%. However, we know that in the big picture, and we're talking about a clinical trial where the patients are selected, the main issue is discontinuation, as you see here, a quarter. But the patients who stay there, they are really doing very well. Obviously, the ECOG, and also I'm going to really reiterate what Farouk has mentioned, I think was an important trial because really kind of demythified the famous FCR, the FCR that has been almost over really achiever in terms of really even people see that they almost curable or like a functional cure on some patient that is almost a myth, right? And there is no doubt that, as mentioned, the progression-free survival is better. And I think we already saw for many years that unmutated, as classical happened with chemoimmunotherapy, or I will mention later on, with fixed duration, biology matters. So when you really have fixed duration, you stop patients with biology that really makes cells grow faster, unmutated IgHV, really going to relapse. The question was what happened in the IgHV mutated. The famous story of the younger fit patient maybe qualify for FCR. I don't believe, I don't do in my practice, but everyone discussing about this famous plateau curves that has been described in the FCR 300 and in the CLL 8 and 10 trials from the German. We now in the last really update that is already different. We don't really see, however, any plateau in any of these two. So I wonder what's going to happen if this plateau is going to show up or not. We already discussed that many of those patients, maybe some of these patients FCR may never really require therapy, but they were. And at the end of the day, once again, those patients who were in the IR arm, they have a very low rates of progressions, right? So at the end, it's tolerability and how those patients, obviously we're talking about younger population, and it's still very surprising about the story of the overall survival, because we forgot about that, and we are discussing about toxicities of ibrutinib and things like that. But look at that. FCR is not really nothing nothing better, right? We now, and I'm sure Farouk has experience with patients that years, because remember, it's the younger patient, the guys who really have that, were exposed for many years to the notorious effects of fludarabine over the bone marrow, and we see the MDSs, we see the AMLs, and even the secondary cancers that, in my opinion, also can happen, obviously happen in all population. We already reviewed the alliance. I think was important because, as we pointed out, there is no role for Rituxan in combination, at least in this case, with ibrutinib. It's not been studied in another. And obviously, the data is very clear, and it's been really shown by Jennifer Boyce many times, and the last one at this point, where you see that there is no difference in the PFS with addition or absence of Rituxan. And again, very, very good data in TP53. That's something that we forget. We forget that TP53 was our unmet need. We really have troubles on this population of patients. Survival was very poor with chemotherapy because we now TP53 pathway is completely become resistant to any chemotherapy, and those patients do pretty bad. And you see here, once again, the IGHV story. Once again, you can argue that BR still performs somewhat okay in some population of the IGHV mutated, but again, bendamustine is not really an easy drug either. It's very immunosuppressive, and we still have very issues in some of them. I really brought that slide that this was kind of presented in a poster. We now all these posters that everyone, all companies go back and forth. And the reason I really brought this one, because really bring my memories when we really were using imatinib for the treatment of CML. Two different conditions, I admit that. But for many years, we really only can cure or could cure CML without allogeneic bone marrow transplant. So we have to convince ourselves that long-term therapy was really good enough. So for what it's worth, and I think it's interesting, this observation, that in this pool analysis of more than 65-year-old patients with an age-matched population, there is really no difference on survival. Something that struck me, because really bring me my memories of why we now still using TKI for life in patients with CML, when we really see really the similar life expectancy of patients who do not really have the condition. Something that I guess we're going to start to see and reflect also this amazing improvement on the overall survival in patients. Obviously, second generation BTKs erupt, as happened again in CML. We have imatinib as the king for many years, but we have nilotinib, bosutinib, dasatinib. Well, we now have the second generation. Try to be more specific and try to really go with less side effects, because at the end of the day is what, again, happened in CML. We really deal with imatinib but have a lot of side effects, so we have to really change. So here they are. Treatment-naive ELEVATE trial, already discussed with Farouk. Maybe I'm going to give my approach of this trial. Very interesting trial, obviously, Acala, Ovino, chlorambucil. The primary endpoint, remember, Acala, Ovino versus Ovino, chlorambucil. Secondary endpoint, Acala versus Ovino, chlorambucil. You know the data is being shown, right? So the question is a second-generation monoclonal antibody very effective, fantastic monoclonal, because we now, obinutuzumab kill at the contact with CD20, besides not much with Rituxan. Is this additional, in this case, matter? Well, we already say, right? This difference is striking. There was no power. In my opinion, that's really difficult. At least I don't really buy it. And why? Because you can argue that will say that, well, I'm going to use combinations in the high risk. But look what happened with 17p is the same. So the question, in my opinion, remains, who is the population who can really benefit? There's some data that was published and is being reported. Maybe IGHV unmutated? Still unclear to me. So in my opinion, it's a suggestion, but it's still a question that is not, to me, fully resolved. Even this difference that we see here, we know there was an imbalance in the two groups, in mutated versus unmutated, and maybe also responsible for this difference. So, in my opinion, not really clear about the addition of this monoclonal. It's true that maybe in some instances where the BTK has a hard time to really penetrate in the bone marrow, and I'm sure Farouk has on this patient who become even more cytopenic at the beginning, you need maybe to empty this bone marrow with a monoclonal, and in these cases, in my practice, is the only reason why I will use a monoclonal such as this one. So what about zanubrutinib? And again, there is no good of two. Now we have three. So let's talk about this drug erupted with this new theory about the half-life, which is kind of interesting, but again, it may not reflect what we see with the previous BTK. But the truth is the only one who stay in the bloodstream for a longer time, right? We have a very long life compared with ibrutinib and acalabrutinib. Is this going to translate in difference? Well, we see a very, very similar data from now. And obviously, we have a very, very nice Sequoia study, the cohort 1 without 17P, also showing by Farouk, comparing zanubrutinib, again, bendamustine rituximab, again, bendamustine rituximab is already buried for our really kind of a clinic, but obviously it's a nice way to really get your drug approved. Obviously, very interesting in my opinion, the cohort 2 and cohort 3, where it's the first time historically we have a very large population of 17 patients in a frontline clinical trial, something that is not being done with any of the other BTKIs. We see the data, it's true, it's early, but as expected, really, we start to see this very, very nice difference between zanubrutinib and the BR. Obviously, we're gonna see more, and obviously, once again, we will see mutated versus unmutated. No doubt the unmutated in time-limited therapy is gonna be the loser, and as you see that mutated and unmutated is not really no difference in the Zanu. And once again, you see this BR who still performs somewhat okay for some patients. In my practice, the only reason I use BR is when patients are completely don't want to be on therapy, or the insurance completely don't have other alternative. Otherwise, I don't think it's a good approach, as we discussed. This is what we see in 17P. We have data reported by John Allen, also the NCI. We see around almost 80% of a PFS at 4 years, something, and with a survival of 90%, something that is completely unprecedented and what we see with chemoimmunotherapy. And again, with a short follow-up, we see a very, very nice PFS, almost 90%. So I think what we're coming here today is to really discuss fixed duration. And obviously, Farouk has really touched upon, but I think now the dilemma is really coming back. We don't have chemoimmunotherapy anymore, but we have regimens that allow patients to stay for a certain period of time and discontinue. And still, the question I really bring here is, who are the patients who can benefit, besides the fact that some patients ask me right away, independent of the age sometimes, oh, doctor, I don't want to stay in therapy for life. So there's patients who are high achievers. They want to really go, they want to beat the disease, even that you tell them that there's no curable disease and the disease is most likely to come. So let's talk about CLL14. And obviously, there was, in my opinion, a very, very important trial who brought back the time-limited therapy for patients with CLL. Older populations, again, we're talking about older population, combination of single agent is not easy. Sometimes you have to work. You have to really, really pay attention to neutropenias and problems that can really bring, and that's the reason we abandoned the combination with monoclonal during the COVID, because the significant issues that we have and the loss of many, many patients in our practice. And this is the data. He showed also the PFS, still very nice, 63, 65%, again, no reached PFS, but you start to see the same phenomenon that we have seen with the high-risk population with the chemoimmunotherapy. Biology matters. Biology matters in the sense that any time that you leave really a cell that has high proliferative capacity with no control really start to proliferate more, and this is what happened with TP53 dysfunction, as well with IGHV unmutated. You could argue that even unmutated, this is a kind of delay. Some patients can benefit, but we don't know what's going to happen with the TP53. Obviously, the German group and many of people even here, they will argue, okay, yes, but they still could really have a second round. Well, we don't know what's going to happen with the second round. We remember with the chemoimmunotherapy, we say, well, the first round could be 4 years PFS, the second round was lower. The only good news maybe is that we are not selecting TP53 as we used to do with FCR or BR. We don't really see an increase of the allele frequency, and obviously we don't really see BCL2 mutation for what it's worth, right? So maybe that's the excuse, but still we don't know what's going to happen with this high risk. So maybe unleash this TP53 or unmutated that's been described many years ago. That's really possibility of really have a second or third hit who really make the patient Richter's or much more aggressive. Obviously, we discussed that the MD, the minimal residual disease is back. It used to be kind of not very popular with FCR, but was really good data that was associated with better PFS and also better overall survival. Very old data with the CLL, with FCR 300. Phil Thompson has published this many times. So here we see the same story, right? And Farouk has showed that you are MRD positive, you do less well at you are MRD negative. If you go even deeper with this new technology or next generation sequencing, 10 to the 4, 10 to the 5, 10 to the 6, maybe give us even a better control. Once again, what is the population who can benefit? Well, in my opinion, just to start and really reflecting what we really used to say, younger, fit, mutated, that's to me a very nice information. And that we didn't have that until CLL 13 came, the Gaia trial, as Farouk said, he's been published in the New England recently. And I think this is the data. And the data to me was great because I was using this combination in the younger mutated patients because it's really see the group of patients who has, for now, when you see the PFS curve, the benefit the most. But here we really corroborate this in the younger population, and I guess, obviously, better tolerated. Maybe we can argue about infection every time that we add a monoclonal antibody of this nature. And you see here, as mentioned before, my colleague, that the MRD is substantially better when you compare chemoimmunotherapy with the doublets. But really also with Rituxan. And again, I fully agree with Farouk. I've been using second generation monoclonal, in this case of inotuzumab, we don't have ofatumumab anymore, in the second line, the relapsed refractory, and even when I saw this data, really, make me feel much better because it's the best monoclonal antibody that I can use. So you're going to use a monoclonal, obviously we have the Murano data, but the Murano data is a lot of liability because you have to really start the bend before, which is more problematic. And if you do the bulking as we do with CLL14, patients do much better. However, again, not much different in the triple. And I agree, every time that you add something to older patient or younger patient, you're going to add toxicity, something that is not well, or this is in there, or maybe in the tables. But obviously, as also Farouk was mentioned, not really the difference, obviously, in the mutated, we're still not going to see early on, as happened in the past. Very clear in the mutated, but very clear, really superior PFS when you compare with chemoimmunotherapy or with Rituxan, because we now, as the CLL11 show and others, the monoclonal matters. Okay, so the new combination. Okay, so, and again, the concept is if we have two really different mechanisms of actions for which we can target CLL, why we do combine? We are oncologists. We do this for a living. We have been doing this with chemo, with anything. We are putting things on top of others. Obviously, the argument, as Farouk was saying, I don't want to use all my really kind of tools in the beginning because what else am I going to do it? But the contra-argument of that is that it's historically what we have done that. And as far as we have something that controls the disease later on, because most of those patients, as we see with the CLL14, do not progress on therapy, progress after the end of therapy, I will feel okay in general. In the patient want to do it, and maybe is the mutated or is good risk. In this case, we're going to challenge the risk category because I guess this is what we need to understand. How better really offer, if patients want, time-limited therapy to a different group of patients. And in this case, we are talking about Captivate. And Captivate, in my opinion, was important because target a specific population of younger patients in the 60 kind of median age, but also really with high risk profile. And you see here this MRD-driven, with this complicated, and sometimes there is not many patients in each of the group, but I like to really see the fixed duration. And I think we're going to really start with the characteristics, very important because we're going to compare with the characteristic of the GLOW study, the randomized. But here, median age 60, and you see high risk category of those patients, right? So younger and risk. Something that we now, time limited, with this combination of BO, well, it's okay, but those patients are going to relapse, as I show you. So is this really good for those patients? Well, I still think we need to really understand better. This is the 3 years. I think what's really, really interesting when we're talking about MRD, we didn't discuss, but the MRD classically in CLL14 is around 3/4, 75% of the patients. Here you see a similar thing, good concordance, peripheral blood, bone marrow. We are doing more and more peripheral blood and maybe confirmed with bone marrow. But I think what's really, really interesting is not really difference in the bulkiness of the patient, bulky or not bulky, very similar. But we start to see the same interesting signal in terms of MRD in patients with mutated versus unmutated. And we see less response in the patient with mutated IGHV with this BCL2 BTK combination we compare with unmutated. And again, you can argue that you can see that the unmutated patient, they're going to respond very well to BTK. There is no difference with single BTK, but it's interesting, the signal that is being reported in many, many trials that we're going to see today, and the one from the UK group from Peter Hillman. So this is the data, and again, I think there is a abstract here, or a poster presented with the 4 years of the Captivate. And again, for now, all treated were okay. It's a fixed duration. So but still, we start to really see the unmutated TP53 here we look really good, but maybe we may start to really see the same phenomenon. I think we need to really continue to follow those data. Disease-free survival, obviously, is a new concept that was introduced in this trial that is really incorporated the fact that patients become from MRD negative to positive, no much different, PFS no much difference, and PFS by IGHV status no difference. So very, very interesting. So this is what happened, right? And the question is, well, I use everything in the beginning. I stop after 15 months. I say that it's 3 months leading with BTK plus 12 months additional with venetoclax. What I do? Well, you put in long-term therapy, and is what most of the patients are being done here, right? Ibrutinib, in these cases, because it was part of the trial, and the patients go to PR and they stays on there. So that will be the argument when you say, well, why I cannot really, why I can use all these good tools? Well, the patient biologically showed that it's not really able to hold it, put in long-term therapy. That's my feeling. What about GLOW? GLOW, the registration trial, as you know, is being submitted to the FDA. It's not being approved here. We don't know it will be approved. It's approved all over the world. It's approved in Europe. It's approved in many other countries, right? But what is the issue with this trial? It's older population. And we now older population a different story. And he really, Farouk emphasized very well. So older population, they don't really tolerate even ibrutinib, but even combinations. And this is the story. Here, real population of CLL, 71-year-old, and again, kind of standard risk, right? So that's the data. The data obviously show that the PFS is superior, nothing unexpected. What I thought that was really interesting is to see the difference in overall survival, something I wasn't expecting. And I think you can really bring, in this case, in this specific case, the role of monoclonal antibodies in the increased infection rate that we always see in any trial that we compare. In this case, we are comparing no monoclonal antibody against monoclonal antibody, and maybe one of the reasons why, and obviously we are really mixing the famous COVID story that obviously is going to be very interesting when tomorrow is being presented by Jennifer about the influence of the COVID in these recent trials where we now, with the very, very deep immunosuppression, can bring COVID and COVID deaths, right? So I thought that was really interesting. Once again, same phenomenon, same biology. IGHV mutated patients has less really percentage compared with the patients with unmutated, and obviously very nice concordance with the peripheral blood PCR. And something interesting that when you see in terms of the sustained response on the lymph node, something that you can understand, because many times we really see, and at least in my practice with the BO, the relapses many times lymph node. In this case, independently of the IGHV status and MRD, patients really have a phenomenal really outcomes in the lymph node. Why? Because we know the BTKs do amazing job really going there. there, and maybe the synergism between these two drugs. We also know that venetoclax is great in the bone marrow compartment, but sometimes, and it's my experience, those lymph nodes have mechanisms of resistance through MCL1, BCXL, who really overcome the power of the BCL2. So this is the last slide on the glow, and I think it's interesting. Obviously, mutated and mutated seems that it's still really similar, although we need to really follow. But I think it's interesting. The MRD status, at least in the mutated, although it's less, doesn't matter. And it's something biologically also is expected. Mutated patient really relapse at very slow pace, and in this case, doesn't matter, they are mutated and mutated. However, maybe it's not the same thing when we see in CLL14. So I think the role of MRD in this combination BTK-BCL2 may not be similar that we have seen with the venetoclax or venetoclax, but I think we need to really start to see more. Obviously, when you see unmutated is when you start to see difference more clearly. As mentioned before, biology matters. Okay, briefly, and I'm not going to really do much in these last 5 minutes, this has the IVO that was really very nicely going to be presented. This is the 4 years. Obviously, I want to really point it out, the median age of those patients, very young. So yes, it's been maybe the population, high risk, younger, it's been also studied these triples, maybe a combination, but again, toxicity matters. I have some patients who really went to Ohio State for these trials and they have to discontinue because persistent febrile neutropenias. Other patients can benefit, but there's no doubt. Addition of more things, we're going to see more toxicity, and maybe it won't really have a huge difference in the outcomes. Obviously, we are now fashioned to do MRD-driven clinical trial. This is Matt Davis' trial with the Acala, venetoclax or venetoclax. Maybe something that we're going to see in the future. Instead of throwing everything, start to really mount different things as patients need it in terms of MRD negative. And again, phase 2, great data. We'll see what's happened and how this may or may not really come up in phase 3 trials. And finally, obviously, the venetoclax, another interesting trial by the Sloan group, where really show, again, dramatic responses. But every time we see these triples in phase 2, they're phenomenal, but we need to really put in work in the real life. And that's the real life things. Obviously, we have been discussing, is the CLL17 or is the magic the one that's going to give you the solution? But maybe we're going to really have, maybe or maybe not, the answer about this time-limited therapy versus really therapy until progression, because I think it's what we're still debating. And at the end of the day, may not really be a problem for everyone. Maybe every patient is going to be different depending on all these biologies, factors, preference, and things that we really discuss. You see plenty of triple therapies that they are coming, and definitely we're going to really have a lot of business in the next year, really looking at these trials and presenting in these things. That's one of the last things, although I think I have a few others. Alternative paradigm. What I personally, and this is my personal opinion, right, what I really lead into more BTK or versus time-limited therapy, even considering that I plus B is in the NCCN guidelines, and you may or may not really want, for the reasons that Farouk said, but there's no doubt that oral single therapy is very convenient. There is no really infusions, and obviously we have very good data in the long run. We have very good data. We see those patients be rescued with venetoclax very well. Obviously, with the intolerance, you can really re-challenge with other BTKs, and I really think it's fascinating response, as Farouk was mentioned, in those patients who has very lymphoma-like. I always said that CLL is a very heterogeneous disease. You have a lymphoma-like, you have a leukemia-like, and you have something in between. But when you have the classical lymphoma-like, oh my goodness, you put the patient on it, with the symptoms goes away, those patients respond dramatically, and they send you chocolates and flowers in the next week, right? Because they are fantastic. So great and good risk, as we discussed, and obviously you have the problem with the toxicity, financial toxicity too, that's for sure. So what we can incorporate the time-limited therapy, obviously, is really financially less problematic. Patients want to really have time-limited therapy. I really like it, the venetoclax or venetoclax in low-risk population, in younger, who may really have long time to really have other therapies that hopefully will bring them to our armamentarium. But obviously, with the I plus B in high-risk population, maybe in lymph node base, it could be a very interesting approach in general that we need to study. And there is no doubt that venetoclax or venetuzumab, and as mentioned before, venetoclax is a fantastic drug in combination with Obino to penetrate in the bone marrow and do a very, very good thing. And obviously, all the issues, the MRD, that is still discussed how we're going to be using this in our thing. I'm not going to really go much of the head-to-head trial. I think Farouk has really do a very good job of seeing the ibrutinib Acala, obviously interesting trial. We showed that there's no really difference, fascinated by the identical PFS in both groups. Again, a very slightly separation, as we really see every time that we see a drug who may be less tolerable, but at the end, not really argument. We saw the Alpine, also interesting, different kind of trial, obviously, not as heavily patients populated, treated, because obviously 17P and Del 11Q was only the enrollment for Elevate relapse refractory, but again, the primary endpoint showed somewhat, well, it's statistically difference in the responses, something that we didn't care in many years, right? Responses are PR most of the times, well, fine, a little more, a little less. But I think it's interesting, the data that is being shown and published in the New England and really put it as a late-breaking abstract. So this difference. So this difference early on, something that we have seen with the Elevate. We love to really see continue how this trial evolve over time, because obviously intolerance on ibrutinib may really play a role, but there is no doubt that the data is the data, and that is being also seen in this high-risk population of 17P. With 5 seconds to go, I only talk about these BTK mutations. That is an issue, obviously. It's not really a big issue, but maybe over the years, in the high-risk population, we're going to see. And why is that for C481S is important? Because it's the residue, the cysteine residue, that really is needed by ibrutinib, acalabrutinib, and zanubrutinib to dock in an irreversible way in the ATP binding pocket. So when there is a mutation there, we forget about it, right? So do we have other mutation? There is other described. Obviously, the one that is also interesting described is the leucine 2 528 tryptophan. That is a very interesting because produce a dead kinase, and that's something interesting for the future application of these drugs. Obviously, we already show, and Farouk showed this data with Pirto, very nice. We're talking about 3 or 5 lines of therapies. I think it's right here, the PFS. Obviously, those patients do okay, but they are not going to be in a remission for a long time. But it's fascinating. I just have a patient in the hospital who was very sick, started on the Pirto. Patient is almost really, really dramatic response. So we see these responses, the question is durability, right? So this is what's happened. It's independent of the mutation, fascinating to me because we thought that was going to be, but the same happened with the ponatinib in CML world. Doesn't matter you have T359, you're going to respond equally. And obviously it doesn't matter you have del17P node and things like that, right? So again, in the future, we're going to start to really see how all these mutations are going to play a role. We have the BTK classical from Acala, for ibrutinib. We see these new mutations, this dead kinase mutation, and now we believe that they are not going to work with Pirto, but maybe with these protein degraders that they are really coming in many, many flavors in our practice. And obviously, this is the end of the presentation. We have amazing, amazing strategies, patient preference, individualized therapy. I think we should take into consideration in the discussions with our patients. And we have really, really long-term data with ibrutinib, but obviously we already explained Farouk very well the issues with ibrutinib. We have amazing data with Acala and start to really see with the Zanu. Pirto is now approved in Mantle, and well, we can use it out of label, obviously, for this very refractory. I will agree. I don't think Pirto is a good strategy to frontline because Pirto has a different mutation profile. And finally, the fixed duration. And fixed duration is a reality. It's here, and we're going to need to study, and we're going to see who are the patients who have benefited the most. Okay? Thank you very much. That's the end, and I think we have some questions. Thank you. What would you do when a patient has aggressive CLL T53 del17P and does not respond well to the BTK? This is a real case. I will start to really wonder what Farouk wants to say, but the first thing I will really consider when a patient is not really responding, really rule out transformation, right? It's something that we have seen in the trials with BTK. It's rare, but sometimes happen. And specifically, BTK is a great way to select the areas of retransformation, because obviously the non-transformation areas respond, and out of the blue, you see residual areas who really start to grow or don't really go down, right? So I think the question is, what do you do with this case? Obviously, rule out these things, do a biopsy in these areas where you suspect it. If it's not really this case, obviously the alternative these days will be do venetoclax-based regimens, right? I will say that will be the alternative. It will be hard sometimes, because in lymphadenopathies, in my experience, Obino, they may really work, but as mentioned, you can really have not really long-term control. Definitely always a challenging cases that they are relatively rare. Farouk, any other take on this?
Yeah, no, I think these are great points. One point I would like to make here is no patient with CLL ever has de novo BTK resistance mutations. That is zero. We've checked this. We have never had any BTK resistance mutation at the time of initial presentation, number one. Number two, we've both treated hundreds of patients. The only one person who did not respond to treatment at all, because if you look at zanubrutinib, ibrutinib, acalabrutinib, all the response rates are in excess of 90+%. Every single patient will respond. The only patient I can remember from my clinic that didn't respond was somebody who had PLL, and that's a different disease biology. So I agree, if somebody's truly unresponsive up front to BTK inhibitor, make sure there is not something else that's going on, and maybe we're missing something. And two, if you do have a patient who's on ibrutinib or acala or zanu for that matter, and now 6 months, 2 years, 5 years down the road, they're actually clinically progressing, I do not stop the BTK inhibitor. That is critical unless you have another plan in place. My common strategy is you have the BTK, you add the venetoclax, you add the obinutuzumab, you debulk, you get a couple of doses in. By the time venetoclax is ready, and that's when you transition to venetoclax, and then there's an overlap that I do, and then I let the BTK go. Sometimes I actually do triple therapy, which again, we can argue about that. But in the 17P patients, I don't stop the venetoclax in that setting after 24 or 12 months, and I may extend the BTK depending on what insurance allows me to do, because I feel that those patients do poorly. But I definitely overlap either with venetoclax and BTK, or definitely CD20 and venetoclax, if the patient, especially if the patient hasn't had CD20 before.
I think it's an excellent point for sure. The famous flares that we really have seen on patients when you discontinue abruptly, ibrutinib is really justified to really continue. In fact, the addition of obinutuzumab will really decrease dramatically the infusion reaction, as the Ohio State has shown, and that we see in the elevate relapse refractory. So for that point of view, I think it's an important thing. I think another important point that you make is that for sure in some high-risk population 17P, you can really offer time-limited therapy. The argument is that, well, there is no reason why you cannot really continue venetoclax if you want to really have continued control, and venetoclax in general can be very well tolerated, and I have plenty of patients in my practice too. So I think we're going to have another questions, and I think it's an interesting one. What is the best time to empty the bone marrow, up front or when really needed to empty the tank? Well, the first thing I'm going to really say that obviously that I mentioned, that this classical CLL really leukemics, right? You don't see lymph nodes, you don't see symptoms. The patient is still discuss why you want to treat it. Well, because you have a hemoglobin of 9 that is being developing, or a spleen, right? But there is no doubt that we do not treat at front if there is not really a good criteria. In this case, the criteria is an anemia, severe anemia less than 10. The platelet is always an argument I tell with my patients, because many of those has ITP-like, so if they are really stable, I don't do much. But definitely, when you see a failure of the bone marrow, it's a good time to really go after that. How are you going to do it? Well, you can really do it with a BTK. You can do it with a more cytotoxic target therapy, as mentioned, but definitely, again, you may have different really dynamics or responses. Let's bring you the next one. In patients who were treated with venetoclax, in how long time they can be treated again with venetoclax? That's a great point. I guess we don't know, but what do you think?
So this was a big discussion that we had recently as part of the NCCN forum too. Nobody knows the answer to that. No, and the only answer we have is with chemoimmunotherapy, when was, if you look at the old NCCN guidelines, There is a reference, and partly from the French data from a long time ago, that if patients who have progressed after getting FCR and if the remission was longer than 3 years, then those patients, when they were retreated with FR or FCR, they had a good response to therapy. If you extrapolate that data to venetoclax, you can make an argument. My other point I wanted to make was, and in response to the bone marrow issue, is I'm not opposed to aggressive therapy. We are lymphoma doctors along with CLL doctors. I'm super duper aggressive. I will lay the kitchen sink on a Burkitt's, for example. So it's not that we're opposed to doing massive amounts of therapy for our patients. BIACOP, bring it on, ABVD, whatever it is. The point is that in incurable malignancies that I can cure, I will throw everything at it up front because I know that that's my best chance of cure. Unfortunately, I haven't seen any data that suggests that anything in CLL is doing that, and that's how I tailor my philosophy on sequential rather than all concurrent.
No, I agree.
And that's just one strategy. I may be wrong.
No, I think it's a good point. I think we're debating each other's. I mean, and again, I think the history of medicine is always debated between the people who want to throw everything in the beginning and the people who want to really keep it. I don't think is right or wrong, but I think I will really say that it's true that in an incurable disease, you can argue that you want to really recycle or to do that. But in certain situations, maybe an argument to really do everything if you're going to have something that they're going to really keep you going up the relapse. So I always say that somewhat is a test that you do with the biology of the disease. And I say that because not everyone, even with famous mutated and mutated, responding in the same way. So we see the 321, for example, mutated or other kind of weird mutated who are very aggressively. So you need to really see how those patients behave upon really stop therapy. And then it's going to really show up. So the patient is not really feasible for that. Well, you know that those patients need to be on therapy for life, as happened in many cases, in my opinion, for this high-risk population, right? So the argument is, can we ever going to be able to do time-limited therapy truly for a significant amount of time in this high risk? We still don't know.
And I think that's another point related to that is, what is considered an adequate MRD? That's the other issue.
I agree.
I mean, even the Sankey plot that you showed for CLL14, there are patients, not a lot, but there are patients at the
Dynamics.
6 month time point with 10 to the minus 6 who actually go to 10 to the minus 5 while they're on venetoclax.
Oh, yeah.
So it's obviously at 10 to the minus 6, you're not curing the disease. Maybe 10 to the minus 7 or 10 to the minus 9 might be the cure.
You're talking about the dynamics. Dynamics is fascinating because obviously we are not really using a lot of dynamics of MRD. Again, I'm going to bring the famous BCR-ABL, and the UK group show very nicely in I+B that you really see how fast this MRD goes and correlate with response as expected, right? The question is, does bring you the question to how long we need the venetoclax. In Murano, we know that many patients were relapsing after the first year. So they relapsed after the second year, they were progressing, but they will have a response, they relapse. Well, in the CLL14, after the 12 months, some patients were in the way down, while some patients were in the way up. So dynamic of response, again, will really teach us biology of our patients, right? And everyone may be different, right? And we need to learn more about those things.
An indirect way to answer the venetoclax question was, how long would an adequate response be? So basically, I think we will probably suggest something like a 2 to 3 year remission duration after venetoclax, and that's a very arbitrary number.
I agree. It's the same story with the FCR, right?
Yeah, if it's less than 2 years,
right.
I
think the question that I think to me fascinates me, how good is going to be the response upon second retreatment? We still don't know the answer.
We have very limited data on that.
Very limited data. Patient, but yes, you can really respond it, but how long is it going to really last? So are we going to see the same biology or the same phenomenon that we see in chemo? Every time we do chemo, we reduce 50% PFS, right? Are we going to see the same with target therapies? I don't think we know. So I think I don't see any more questions here in my chat. So I think we're going to really close, and we're looking forward to your questions, as we have said. But I think at the end of the day, I think you need to really go to the post-activity survey and answer all these questions. And I think I'm going to really finish this presentation tonight. Thank you so much for your attention.